Welcome to Session 2 of the Public Health Surveillance course. In this session, we'll cover the principles of public health surveillance, including topics such as establishing a surveillance system. In terms of lecture content, we'll discuss considerations to take into account when planning a new surveillance system, and then we'll delve into some of the key attributes of surveillance systems, which can be useful not only for when you're designing a new surveillance system, but also when you're evaluating an existing surveillance system. For example, to assess the extent to which a surveillance system is serving its purpose, or whether a surveillance system is useful from a public health standpoint. And I think this is a great quote from Bill Foege, a former director of the Centers for Disease Control, that's directly related to surveillance. He said, "The reason for collecting, analyzing, and disseminating information on a disease is to control that disease, and that collection and analysis should not be allowed to consume resources if action does not follow." And I think that's a key concept that we should be paying attention to when we're thinking about the attributes of surveillance systems and the principles of public health surveillance. Because there is an intended link to action for both disease prevention and control in surveillance systems, or there should be. Let's revisit the definition of public health surveillance that we're using for the course. I've highlighted some key words for us to pay attention to here on this slide. Recall that public health surveillance is the ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning and implementation and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control, and to other stakeholders, including those who report information on individual cases. Having this in the back of our minds will be useful as we talk about surveillance systems and considerations to take into account when designing them, as well as their attributes, which we'll talk about as well. So that's the definition of public health surveillance. But what is a public health surveillance system? A surveillance system includes many of the things that we mentioned in the definition of public health surveillance, like data collection, analysis, and interpretation and dissemination. And of course, it's all these things, but plus a number of other things, including a wide range of support services. For example, a surveillance system, in order to be most effective and to get buy-in from people who are stakeholders, it's important to do education among clinicians and laboratorians about, for example, reporting requirements that they may be subject to and the reasons why they're expected to share reportable information to health departments. Surveillance systems require staff accessibility for consultation by providers and laboratories, and often you need to be available 24/7 for acute conditions. And also, the availability is important to receive reports from providers and labs as these cases occur. Surveillance systems need to have data quality assurance and quality control. And health department staffs running the surveillance system should have also a visible presence in the healthcare community to help establish and maintain relationships. And finally, surveillance systems need to have working systems or mechanisms in place for disseminating things like alerts, bulletins, and recommendations, and the routine reports or other end products of the surveillance system that translates the data into epidemiologic information. As I mentioned earlier, that the surveillance part on the left side of the slide here, collection, analysis, interpretation, and dissemination, really implies some intended link between the surveillance system and some subsequent related public health action. So surveillance systems should inform the public health action, including things like setting priorities for public health, or planning and implementing and evaluating disease investigation, control, and prevention measures. When assessing a surveillance system, it's important to always think and identify where there's a system's intended link to public health action, where that link is, and also what are the public health actions that are typically intended to be taken as a result of information gathered in the surveillance system. So what are some of the considerations in establishing a surveillance system then? Many of them are listed here, and we're going to go through each of these one by one and expand on some of them. A fundamental consideration when planning a new surveillance system is the extent to which it's justified or needed. In considering this question, you may be thinking about things like whether the disease is important to public health or whether it could be potentially important one day. whether surveillance may be necessary to guide, monitor, and evaluate prevention or control measures that are being put in place, whether surveillance may be necessary to establish the baseline incidence of a condition, because we know that there may be new prevention or control opportunities that are coming on the horizon. So even if they don't exist now, establishing surveillance can help establish the baseline. Another justification is whether a surveillance system might be justified because the disease is new and data are needed. We don't really know that much. It might be, for example, that we don't know enough about the burden of a disease, or we need to better quantify it or characterize it. And finally, a new surveillance system is more justifiable if available data and alternative sources of data really won't suffice to give the information that's needed. In this situation, there's a need to set up a system to get information that doesn't exist anywhere else. And here are some of the things that you might consider as criteria for assessing or identifying high priority health events that might benefit from having a new surveillance system. First and foremost is the frequency with which a health event occurs and the extent to which it creates a burden on public health. So you're thinking about things like incidence, prevalence, and mortality rates. Another consideration relates to the severity of the condition, so things like the case fatality rate for the health event or the hospitalization rate. And if it's a cause of disability, then it may be important to examine some of the burden of disease metrics that we discussed in week 1 of the course, such as disability-adjusted life years or years of life lost and quality-adjusted life years. It's also important to consider the direct and indirect costs. That is, the cost of the healthcare systems, the cost to society, or both. Another consideration is how preventable the condition is, or to what extent is there a public health action that can follow as a result of understanding the disease burden better. The extent to which a condition is communicable or contagious may be a consideration, as is public interest or public concern around that particular issue. And finally, whether or not it's a new disease or event or condition factors into trying to decide whether or not a health event should undergo surveillance or whether a new surveillance system should be developed. Once you have a clear justification for establishing a surveillance system, then you can begin to think about what the objectives of that surveillance system might be. These objectives also will be directly informed by the justification for the surveillance system. Every public health surveillance system should have clearly stated objectives. Here are some common objectives of surveillance systems, just to give you a sense of what they can look like. I won't read through all of them, but a sample includes estimating the magnitude of a public health problem. That's a bread and butter objective of many surveillance systems. Another one is understanding the natural history of a disease or condition, or identifying who target populations for interventions might be. In other words, who's most at risk or who's most affected by a particular health issue. Another reason is to detect outbreaks early so that action can take place. And documenting the distribution and spread of a health event is another example. And generating hypotheses about the etiology and risk factors of the health condition or event can be important when little is known about this. And finally, evaluating prevention and control strategies, especially those that might be implemented by health departments. You can use surveillance systems to assess the extent to which these programs and strategies are having their desired or intended impact. There are many possible objectives for surveillance systems, and there are always new things on the horizon that require creative thinking about what a surveillance system should do or what its objectives are. And I encourage you to think about the definition of public health surveillance when thinking about the goals of a surveillance system. Other than that, there's plenty of room to be creative in thinking about the goals of any new surveillance system and how it can be most useful and impactful. Another important consideration for many, but not all surveillance systems is the case definition. The choice of the case definition is really largely informed by the objectives of the surveillance system. For case-based surveillance systems, that is, surveillance systems that track the occurrence of cases of a health condition, the case definition is used to define the event under surveillance. What are the events that are under surveillance that need to be tracked and counted? These case definitions are central to many surveillance systems, and for that reason, we'll spend a bit of time on this part, as part of establishing a surveillance system. We'll go through some examples of case definitions and talk about the rationale behind them. A case definition is basically a standard set of criteria for determining whether an individual should be counted by the surveillance system as having a particular disease or health-related condition that's under surveillance. The use of a standard case definition helps to ensure the consistency over time, location, and clinical practice. And the case definition usually has components consisting of clinical criteria, laboratory criteria, and sometimes criteria on time, place, and person, or epidemiologic exposures. A case definition can also have things like degrees of certainty. For example, a case could be a suspect case or they can be a confirmed case, depending on whether, say, they've had some kind of laboratory test that confirms their diagnosis or not. Case definitions should also be understandable and acceptable to the people who have to use them, of course. They relate, the case definitions that relate to clinical diagnoses, which might include laboratory information or signs and symptoms of disease, which is common when there's no lab test available. But there are other kinds of events that require different levels of confirmation or documentation. So if you have a surveillance system that aims to track, say, measles vaccination events in children, and then your case definition may rely on the self-report of vaccination, or it could require some kind of documentation of vaccination, like through a medical record. Ideally, the case definition should be sufficiently sensitive to identify most persons with the condition or event under surveillance, but it also has to be sufficiently specific to include persons who don't have the condition or event. So let's dig a little deeper. Here's an example of a case definition that was used for HIV/AIDS surveillance in New York. The goal of that surveillance system is to monitor the HIV/AIDS epidemic, plan primary and secondary prevention activities, and improve access to the treatment for HIV. The case definition specifies criteria of person, place, and time, as well as clinical and laboratory information. The case definition specifies any person anywhere in New York State who, on or after June 2001, was positive for antibodies to HIV or whose HIV is detectable in the blood by an HIV viral load test. And a person with HIV who also has AIDS or advanced HIV is a further classification that can be applied when someone with HIV also has immunodeficiency, as determined by a test called the CD4 test or a diagnosis of specific AIDS-defining illnesses. So you can appreciate some of the detail and the specificity that's used in case definitions for health conditions under surveillance. And this is an example of a case definition that was updated and changed a fair bit over time. And that can happen when the goals of surveillance may change. For example, if there's a new development and maybe some new treatments that become available or a vaccine, or the surveillance system might need to serve new functions that change over time. Things like laboratory tests that become improved or come available for the first time may change the case definition, and when that happens, it's really important to take a close look at whether your surveillance system or whether your case definition needs to be updated. In this HIV/AIDS example, New York's surveillance system was expanded in 2001 to track HIV in addition to AIDS, and we're going to go into this as a detailed example in an upcoming session of the course. To develop a case definition, you need to think in detail about what constitutes a case and how to define a case. That is, how are you going to decide whether or not to count an event or a diagnosis or an exposure? What constitutes the presence or absence of an exposure? What constitutes the presence or absence of a risk factor? It's important to define these things, and how you define them should really be driven in large part by the overall goals of the surveillance system. You'll hear me say this a lot. This implies that you could have two surveillance systems for the same sort of health condition, but if the goals for each surveillance system are different, they might have different case definitions. Consider the example of a diabetes surveillance system. If the goal of your diabetes surveillance system is to inform primary prevention for diabetes, your surveillance system may have a case definition that includes prediabetes or early onset diabetes. Whereas if the goals of a surveillance system is to inform strategies for preventing some of the bad outcomes among people who already have diabetes, you might count diabetes-related hospitalizations or deaths as cases. So it really is important to think about case definitions in relation to the goals of the surveillance system. And finally, as I alluded to earlier, remember that not all surveillance systems are the more traditional case-based surveillance systems with cases as the fundamental unit under surveillance. However, the concept still applies to many other types of surveillance systems that we'll be covering in subsequent sessions. As you could appreciate with the example of HIV/AIDS, it's important to be explicit with case definitions. So when applicable, you'll want to have a case definition that specifies person, place, and time so that you can do basic epidemiology. You'll want to include clinical criteria, laboratory criteria, and epidemiological criteria. For example, exposure-related information like travel history or other information that's necessary to classify people. Not every report to a surveillance system from a provider or a laboratory is going to represent a case. So a good surveillance system should always gather enough information on people reported to it to make a clear determination of whether or not they meet the case definition. The surveillance system makes this determination, not the providers or labs. Sometimes an investigation or an interview might be required on the part of the health department to obtain the necessary information to make the case status determination. So ideally, all the information that you need to make that determination is ultimately available in the surveillance system. You also don't want to end up excluding potential cases because you don't have enough information on them. So if this is a concern, and it often is, you may want to consider a classification system that's based on the likelihood that a given report to the system is a true case. For example, classifications of possible case, probable case, and confirmed cases based on how much information you might have on them in the system. And we'll go through some examples of these in the next few slides. Another consideration around the case definition relates to the causal pathway of disease or disability. It's important to consider what you know or don't know about the causal pathway of a disease or disability that you're trying to track, impact, control, or prevent. At what point along this pathway is the surveillance system going to be operating? At what point on the causal pathway can the information gathered be subsequently used to achieve the surveillance system's goals? As we've discussed, surveillance systems should provide basic information for public health action. So it's helpful to think where along this pathway information can be gathered, or if the surveillance system will provide information that's useful for the interventions that are available. For example, with the earlier diabetes surveillance system, is it helpful to have information on the pre-symptomatic phase, or is the system primarily focused on outcomes or sequelae of the health condition? But you can think about the progression here. Is there something about the environment that's important to be part of the surveillance system? Is there a specific hazard or infectious agent involved? What about individual behaviors or risk factors, other exposures? And then there's the disease process, starting with the pre-symptomatic phase of disease where screening may be relevant. Depending on the surveillance system, diagnoses based on screening can be part of the case definition. This is followed by when the disease might become apparent and potentially diagnosable based on symptoms. In the apparent disease phase, when a person sees a healthcare provider for their symptoms, it's possible for them to be diagnosed, which is an event that can be captured in a surveillance system easily. And then, of course, there's the outcome of death due to a condition under surveillance. It's an outcome that's much farther along in the disease process, the end of it, in fact, but it may be the place that your surveillance system starts, depending on its goals. So another consideration about case definitions is whether you need to classify cases according to clinical and exposure information. So clinical classifications may be things like mild or severe disease, or exposure information that might include something like whether the person ate at a particular restaurant or had traveled before becoming ill. Usually, case definitions require both the clinical and epidemiological exposure-related information, but both types of information don't always exist in one place together. You can usually find the clinical information in the medical record, but the exposure information usually won't be available there, and you'll have to have other sources for that information. For example, patient interviews. For common diseases, if there's a lot of classification that needs to happen, where possible, it might be efficient to try and automate parts of the classification process rather than having a human sort through every single case to identify them. And also, it's important to keep in mind that if you're running a surveillance system that requires extraction of data from medical records, It's important to try to standardize the extraction process across institutions or employees of the health department or hospital. The standards and the processes for doing these things have to be specified to ensure that the level of information you get from one provider to the next or from one health department staff member to the next is consistent and therefore useful and interpretable when reports become merged as part of a single surveillance system. Here's another example case definition that was used during an outbreak of hemorrhagic E. coli 0157H7. This was in the context of an outbreak investigation, so the goal here was to look for specific serotypes of E. coli associated with a county fair in upstate New York in order to determine what the likely cause of the outbreak was. In other words, what were the risk factors for infection? As you can see, the case definition that was used specified person, place, and time, as well as clinical and lab information. For person, it had to be a visitor of the Washington County Fair where the outbreak was happening, and they could have lived or worked anywhere, and they didn't have to be a Washington County resident, but they did have to attend that fair. They also had to have onset of the infection since late August of 2001, and then some clinical and laboratory criteria. This is also an example of a case definition that has a classification system. A confirmed case was a case of diarrhea within 10 days after attending the Washington County Fair with a stool sample that was positive for E. coli 0157H7. Now, you could have also added a criteria of bloody diarrhea. They didn't, but that would have been another way of increasing the specificity of the case definition. And a suspect case was anyone with diarrhea within 10 days after attending the Washington County Fair, but without a lab test that was positive. You could have added the condition of bloody diarrhea again here. These are the kinds of considerations that epidemiologists factor in when figuring out what the most useful and optimal case definition might be, as always, though, given the goals of the surveillance system. And here's an example of the epi curve that was generated as a result of this outbreak, applying two different classifications in the case definition. In orange, you can see the culture-confirmed cases or the confirmed cases based on the definition on the prior slide. And the yellow shaded section of the slide shows those cases that were the so-called suspect cases. They met all of the case definition criteria, but they didn't have a confirmatory lab test. You can get a sense of what the impact of requiring a lab test as part of the case definition would be. It would basically reduce the number of cases that you'd capture in the surveillance system. And by allowing two levels of criteria in the case definition, though, you'll capture more cases, which will involve more work. It may be important, though, if you're worried that many or most of the cases of the conditions you're interested in won't have a specimen or a laboratory test available. In this case, including both the culture-confirmed and the suspect cases, they both seem to tell the same general story of when the outbreak peaked. Including the suspect cases also gives you the added information that some cases may have occurred even a little bit earlier than maybe would have been noticed if the case definition had just been limited to culture-confirmed cases. And of course, case definitions don't only apply to infectious diseases that might be under surveillance. Here's an example of a surveillance system for fatal injuries in New York State. The goal of this surveillance system is to monitor fatal injuries and identify persons at increased risk for fatal injury. Their case definition was any death in a New York State resident occurring in New York State where injury was assigned as the underlying cause of death. And they specify International Statistical Classification of Disease codes, or ICD-10 codes, that have an external cause of injury listed. You can see that they're being very specific about which codes would be used to identify cases to be counted as part of this fatal injury surveillance system. It may be possible that some individuals who died of a fatal injury were not classified correctly as having died of one, and those might be missed. But it may have been determined that using ICD codes on the death certificates provides adequate sensitivity and specificity as it relates to the goals of the surveillance system. One helpful question to ask is whether you need to capture cases that cut across the entire clinical spectrum of disease. If surveillance system objectives can be met only by tracking more severe cases, that could really simplify things. You don't have to capture information on every single case of the condition. You could focus, for example, only on the deaths, or only on the cases that result in admission to a hospital, or only on the cases that are in intensive care units. This reduces the universe of individuals that need to be counted and the resources needed to run the surveillance systems. This concept relates to the fact that for many health conditions, there's an iceberg phenomenon where you have a spectrum of disease that goes from asymptomatic to mild illness to more severe illness, and at the tip of the iceberg, those cases that might result in hospitalization or worse, death. This is the example of West Nile infection. 80% of people infected will not have any symptoms, and the remaining 20% do have symptoms. Some of them are mild and some of them are very severe. So if this kind of information is known about the spectrum of disease under surveillance, it may be that the goals of your surveillance system can be met without having to capture information across the entire spectrum of disease. This will allow you to focus on the smaller number of cases or to conduct case finding in a specific place, for example, in the hospital. Here's the surveillance case definition that was used in the outbreak of West Nile virus in 1999, where the goal was to put into place a surveillance system that's able to quickly detect human outbreaks of West Nile infection. You can see the person, place, time, clinical, and laboratory details specified here in the case definition. Our last example case definition is one that was used in surveillance for measles. The surveillance goal here is to rapidly identify cases to prevent further spread. So it's informing a public health action. There's a clinical component, a laboratory component, and as we've discussed before, a classification system of suspected, probable, and confirmed. Every time you see a case definition, think about person, place, time, clinical, lab, and sometimes epidemiologic criteria. A good case definition will specify many and sometimes all of these things. Once you've got a case definition, you need to begin to operationalize things, operationalize aspects of your surveillance system. How will the data be collected? What about quality control and validation of those data? Who will analyze and disseminate the data? It's all the things that are part of a system that need to be specified for the surveillance system to work, including the dissemination activities. So operational considerations include things like what will be the procedures for collecting, analyzing, interpreting, and disseminating the information that comes in. Just for efficiency's sake, it's always important to think about how other related or similar surveillance systems might be working and whether there's a way for you to piggyback on those existing systems when possible. Is it an active or a passive surveillance system? We'll come back to these attributes in a bit. Who's expected to report information to the system? Will they use forms to report cases? What forms will be used and what information is collected on them? How will the health department process those forms? Does the health department or does the surveillance system need personal identifiers for this surveillance system to work? If so, you need to be thinking about how to maintain security and confidentiality of all the information that's being sent and received. What software and data transfer protocols will be used? You'll be generating tables, graphs, and maps routinely, but how frequently will you update them? This can be in real time, such as whenever you hear about a new case, or maybe every week, month, or every quarter. But you should be looking at the data routinely, whatever the frequency. And then with that frequency, you'll disseminate surveillance data in the form of information to the public or stakeholders who may need to know what format will you be using and who's the most important target audience for those dissemination activities, and what kinds of staff or other resources might you need. So there's a host of operational considerations that come into play, and these are just a few of the big ones. Related to operations is whether or not you need detailed medical information. You may need it, for example, to classify cases as suspect, probable, or confirmed, or severe or mild. You may need it to check that a prescription was given out was the correct one. And then once you realize that you may need this information, how do you go about getting it? It's labor intensive, and so there's a cost and a need for resources. In other words, somebody will have to pay for it. The health department staff interviewing providers can be one approach. They go out and talk to providers and they get some of the key medical information they might need. The staff could also review and abstract a medical record to get the information. You can have providers fill out forms, either paper forms or electronic, or hospital employees can fill out the forms. But either way, there's got to be a system in place, and there's going to be a need for resources, including staff time, to get it done. And you can ask the question of whether or not you can get all the information you might need directly from electronic health records or other administrative data systems. If the information that you need is available there, then it can be just a question of developing the code and algorithms to abstract the information that you need, maybe with minimal effort for data collection. If you are thinking about using electronic health records or electronic sources, then the key question is whether you can fully ascertain all the information you need to determine case status from these sources. For some diseases, the lab reports themselves can be enough to tell if someone meets a case definition. Some examples included here include lab tests for meningococcal diseases, or IgM tests for hepatitis A and B and other viruses, or a test indicating an elevated blood lead level. But for other diseases, things can be more complex, and it might not be possible to get all the information needed to see if someone meets the case definition solely using electronic sources, such as a health record or lab information system. So other kinds of information that you might need include things like the date of illness onset or the date when the person first started feeling ill, which may or may not be readily available in the electronic health record. The date of diagnosis likely will be there, but the date they started having symptoms may have been well before that, and it's part of the patient's history, but maybe not readily available in the electronic health record as a field. Other things that might not be available in EHRs include things like whether there was a travel history or a tick bite or other epidemiologic exposure of interest. Even if you can't get all the information you need from these electronic sources, it may be that electronic health records or other electronic systems can help identify cases that you could then reach out and do further follow-up to get the additional information you need. We'll dedicate an entire lecture to administrative records and their utilization as data sources for surveillance systems, but to distill a key point here, since there's a correlation between ICD codes, billing systems, and the actual clinical diagnoses, this can allow administrative records to serve as data sources for surveillance. However, the degree of correlation varies depending on the specific disease in question. For instance, employing hospital discharge data for surveillance might yield effective results for one disease, but prove less effective for another. And we'll delve into illustrative examples of this phenomenon in upcoming sessions. Another essential operational aspect to consider is whether you need comprehensive information about all individuals or events that align with the case definition or not. Accumulated extensive data on all cases can compromise data quality within the surveillance system, such as problems with completeness or accuracy. Additionally, it might impede with the timely flow of information. One solution is to employ a sampling-based approach. In this approach, you gather a set of core data on all cases and do more in-depth case data collection in a representative sample or systematic sample of other cases. Various strategic options exist. For example, the focus of sampling could be on cases with an unusual presentation or on other subgroups such as by age, gender, or geographic locations, or on cases that occur during specific times of the year. Another approach involves concentrating data collection in more detail on cases that are reported during suspected outbreaks. Finally, you could also direct attention towards a subset of providers or healthcare facilities that are already equipped with enhanced data mechanisms or who have committed to collaborating more closely with the health department on surveillance. Each of these strategies can significantly enhance efficiency by augmenting the richness of information beyond basic demographic data that is derived from the provider and laboratory reports. Another important operational consideration is whether you need to follow up with cases after they're reported, for example, to ensure proper treatment or identify and manage the contacts who may have been exposed, or by providing treatment or vaccinations. De-identified data won't suffice in this situation. Electronic data sources might lack complete or up-to-date location details to find people, and so you may need dedicated staff time to collecting and verifying certain data. This is not cheap. Often surveillance systems that necessitate contacting individual cases for follow-up also need to be very timely, adding another layer of resource needs. But some data systems, hopefully increasingly so, might possess adequate exposure information for public health surveillance. Related to contacting cases is whether the system needs to support case management of those cases. For instance, if one of the surveillance system's objectives is to help ensure and monitor proper treatment or the completion of treatment, such as in the case of tuberculosis, the system needs to be integrated with case management. While tracking and supporting case management doesn't usually happen at the state or federal level, it does hold significance at the local level where these types of activities tend to be coordinated. Case management generally requires detailed data collection, frequent status updates, and information sharing and management reports. Another operational factor to consider is whether the surveillance system needs information on outcomes after cases are reported, such as mortality or the emergence of complications that happen after they've been reported as a case in the surveillance system. This kind of follow-up data can be sourced from the same or different channels as the initial clinical or laboratory information, but in these situations, effective tools for linking the updated outcome information on the same individual in the surveillance system are essential. This form of follow-up can be resource intensive, particularly in cases of mortality where a surveillance system registry is matched with a death registry. While demanding additional effort and technical skills from the surveillance team, though, this kind of follow-up can be adding tremendous value in some instances to the epidemiological information that you can gain. With the increasing availability of electronic data, surveillance systems increasingly need to amalgamate information on the same individual from different data sources. So this approach holds the potential to alleviate surveillance substantially, albeit with a corresponding increase in complexity. For instance, clinical case reports from providers, lab results from laboratories, and vital records from a death registry might all independently gather information needed by the surveillance system. Once the data is reported by each source, it has to be accurately merged and then massaged to derive epidemiological insights. This requires planning for a substantial amount of record matching and deduplication as part of the surveillance system's routine operations. It may be possible to automate some of this work, but even that will involve the need for some staff time to oversee the process and ensure data quality. Another consideration is whether the surveillance needs to run all year round. Does the system need to run all year? In the context of seasonal conditions or health events, this might not be the case. Take influenza, for example, which isn't necessarily active during the entire year, or mosquito-borne illness, for which epidemics are pretty much absent during winter in many locations. In these situations, a surveillance system could potentially operate selectively during specific seasons. Similarly, you might be able to deploy certain types of surveillance only when known threats exist, such as activating a bioterror-related surveillance system when certain planned events occur, such as the Olympics or the US Open. Additionally, the intensity of a surveillance system can be escalated or de-escalated, such as periodically transitioning from a mostly passive surveillance system where the health department staff wait for reports to arrive, or to one that's more active where they're out looking for new cases systematically. While the notion of conserving resources by deploying surveillance selectively or seasonally is appealing, it's important to also remember that starting and stopping or cycling a surveillance system costs money too. Another consideration is whether or not you could use sentinel sites for surveillance. Instead of requiring or expecting reporting from every provider in every location, you might be able to get what you need just by focusing on a subset of hospitals or healthcare providers. This makes sense if you don't need to count every single case and you just need information about the cases that may be occurring at any given time. You can do trends-related analyses, even though you're not counting all cases. Sentinel surveillance also makes sense if each individual case that occurs doesn't need to be contacted or followed up by the health department, as we discussed earlier, such as those for case management or contact tracing. It's especially helpful when the sites are reasonably representative of all that of all the sites that diagnose cases under surveillance. So you may want to avoid only choosing certain kinds of sentinel sites. For example, private hospitals only, especially if it's likely that the cases occurring at sentinel sites are different in potentially important ways from those at, say, public hospitals. The best scenario is that you have a known universe of sites or healthcare providers that you're choosing your sentinel sites from. And you can say, okay, well, we're going to systematically choose a proportion of those sites. So if you know the sampling fraction, that strengthens the ability to generalize beyond the sentinel sites. And since you're working with fewer providers and cases, you can spend resources collecting more detailed clinical and laboratory data, and this allows the surveillance system to add more depth as opposed to breadth. And if that's what you need to achieve the goals of your surveillance system, then sentinel surveillance might work well for you. Another consideration is whether you need to capture information about diseases outside of humans, for example, in animals. Increasingly, we've been seeing the value of wastewater surveillance for COVID and other pathogens. In these cases, you need a data model that allows for and supports collecting information on animal cases or environmental sources. And when you do that, you may need to get data from, say, veterinarians or sanitarians, as opposed to or in addition to healthcare providers. You may need to work with veterinary hospitals, veterinary labs, animal shelters, animal controls, and so forth. And you may need to get additional staff at the health department that have expertise in these particular areas. We don't train in them really in public health schools so much, but as opposed to a regular epidemiologist, you might need a veterinary epidemiologist to support some of these surveillance systems, and they can help to better develop and maintain relationships with those needed for the surveillance system's success. Cooperation is another key consideration when establishing a surveillance system. Surveillance really isn't something that a health department does on its own. It's a cooperative activity. You usually need healthcare providers and laboratorians to engage with you in the process. They're the ones that ultimately provide case reports and provide laboratory test results. The DOH staff, health department staff, will process and aggregate those reports and translate it into actionable epidemiologic information. But you need to cooperate closely with the people who are reporting, as well as others who use the information, such as public health program managers and policy makers and other stakeholders. You need their cooperation too. And so you'll need their input, and you need to understand what information is useful to them so that the surveillance system can be that much more impactful. For these reasons, when planning a new surveillance system, it's critical to have a dialogue and get buy-in from these stakeholders early in the process. And this will help ensure that they will support the surveillance system and use the information that it generates. If provider and laboratory reporting is necessary for the surveillance system to adequately function, it may not be enough just to pass a law that requires reporting. We know this because even for situations and conditions where reporting is required by law, there's massive underreporting, especially by healthcare providers. In addition to requiring reporting, public health agencies need to educate and inform healthcare providers and labs not only of their responsibility to report, but also why they're being asked to do so. It's very important that they understand why the health department is expecting this from them and how the information will be used. Whenever possible, use the data from the surveillance system to provide healthcare providers with timely feedback that could be useful to them in the prevention, diagnosis, and treatment of the condition. And finally, regular dissemination of reports will help ensure that decision makers have the information that they want. This is much more likely to happen if you involve them in the planning steps. It helps ensure that the surveillance system is useful to these stakeholders. Once you've designed your surveillance system, there are issues to consider related to its implementation. In general, it's best to implement relatively quickly after you have completed the planning phase of the surveillance system. This is soon after you've ensured cooperation from key stakeholders by involving them in the process of articulating the surveillance system goals and designing it. So it's best the data collection and reporting begin while these key stakeholders are still motivated. So as soon as you have procedures and systems in place, you'll want to start the data collection process. And then also, as soon as you can, as soon as it makes sense, summarize these data and disseminate the data you're receiving in the form of useful information to stakeholders. The dissemination part is an essential part of surveillance. It's part of our definition, as you saw, and it's part of the process of continually engaging stakeholders. Share the data, share the responsibility, and share the credit for the useful information that comes out of the system, and other related successes as well. And there are a host of other considerations, which I'll just go through really quickly here. I hope it's been clear that it's super important to have clear objectives for your surveillance system, ideally with those objectives informed by stakeholders in the surveillance system. Everything else flows from this because you then design the surveillance system to be successful at meeting those objectives. Related, you need to make decisions about whether or not something should be part of the surveillance system or not. And this should be based on the system's objectives, of course. But this way, you can always ensure that your surveillance system is lean, that there's not too much mission creep or bloat in the system. You really want to keep it closely focused on the stated and agreed upon objectives, which should really be revisited from time to time as well. To the point of efficiency, a surveillance system shouldn't collect more data that are needed to achieve its objectives. It's really labor intensive to collect and report data, and if they're not used, it can really erode trust and cooperation. The people that you're hoping to engage in this surveillance system are usually pretty busy with other jobs. It's important to show those people providing the reports how the data are being used. How does the health department use it? And how are the other stakeholders using it? How has it led to impact in the world? It's important to value and build on the personal relationships that you've built as part of this process, and always do as much as possible to make it easy for stakeholders who are often very busy with competing demands to engage in the process. So make it as easy as possible. And if there are things that the health department can do to remove barriers to stakeholder engagement, including and especially the reporting of information, they should really try to do that. It's also important for health department staff to be available to consult with providers and labs on clinical and public health issues. So if there's something that's related to the surveillance system or the condition under surveillance, they should really be available to engage with folks on these issues. We'll see examples of why it's important to build some redundancy into reporting systems. So, for example, you might have providers and labs reporting the same information because you know that not all of them are going to report every single time, and so it helps to fill gaps in the reporting system. There's also a need to take a look at and routinely analyze the reported data and interpret it. You need to break it down by person, place, and time. And that way you can help ensure that the related information is useful, and that it's received by everyone and that it's interpreted together. You'll develop a story from the data that you get from surveillance, and it needs to be interpreted in the context of other things that are happening related to that condition. Finally, be confident about the value of the surveillance system and its goals, as well as the purpose of surveillance in the larger public health approach. This will help convey that confidence to those that will be providing the surveillance data. They may not always be tuned into public health and what public health is doing. They're generally more focused on the role of providing clinical or laboratory services, but you can help them see the bigger picture of how the surveillance system is going to help promote and protect public health. You can make that link for them. That's it for this session.